sort of throaty, what's the word I'm looking for? Somebody do a Britney Spears imitation. But anyway, what we're finding is that type of sound, if you want to get a deep guttural sound, is actually caused by some of these chambers, these superior chambers superior to the vocal cords, actually slapping against the epiglottis. And so again, you have a variety of ways of changing and modulating the sound and the quality of the voice that we hadn't quite realized. All right. So the basic theme here as we conclude this discussion is that these, so we have a better illustration here. You have a picture of these, the true vocal cords that form the glottis, what Acklin called the rima glottis. And as we indicated, the length and the tension, and that's what this slide is all about, the length and the tension of those vocal cords determines the pitch, determines more precisely, I should say, the frequency of the sound that is generated by the vocal cords. All right, so unfortunately, the relationship is not like that of a guitar string. Our voice is a little more complicated than a guitar string. But in general, what you should understand is that those small muscles, and you have a list of them, you have a table of them, you don't need to know all their names. But those intrinsic muscles of the larynx, primarily what they're doing is they're changing changing the position of the cartilages relative to one another. What were the cartilages? Well, we noticed that the cricoid cartilage would float up and down relative to the thyroid cartilage. And then what we're looking at here is these are the arytenoid cartilages here. There's an arytenoid, there's an arytenoid. And you can see those arytenoids are posterior to the cords themselves and attached in such a way that their movement is particularly important for the generation of sound. And they have the ability to move laterally, and they have the ability to move back and forth. And so that adds considerable, and of course, once again, it's those intrinsic laryngeal muscles that are responsible for changing the relative position of these cartilages. So in this figure, I just want to make sure you understand a few of the structures here. Of course, the dorsum of the tongue is at the bottom, so this would be the front, the bottom here. This is the anterior. And then this is the molecular region of the tongue. We talked about the molecular membranes when we talked about the tongue. And then there's the epiglottis. That's the epiglottis in there. And though it's not clear, of course, the black space is the rima. That's the airway, or we're looking down into the trachea. But this portion right here, this is the true chord. And then you don't really see it. This is the false chord here. All this is the false chord. And then you don't see it, but in between them, where that black line is, that's the ventricle or vestibule. That's that little pocket that we see right here. And then some of these cartilages, the arytenoids, and then there's some other cartilages called cornuate or cornicate cartilages on top here, but they're positioned along this plane. He's not very loud. Let's see if I can figure out what the deal is here.
Here are the vocal processes of the arytenoid cartilages. We'll add the vocal ligaments to the picture. Here they are. The vocal ligaments run from the thyroid cartilage in the midline to the tips of the vocal processes of the arytenoid cartilages. They're fixed in front and highly mobile behind. Their tension is affected by the tilt of the cricoid cartilage. The gap between the vocal ligaments is affected by a rotation of the arytenoid cartilage. The vocal ligament isn't an isolated structure. It's the free upper border of this cone-shaped sheet of membrane, the conus elasticus. The conus elasticus is attached below, all the way along the upper border of the cricoid cartilage. Its upper border, which is free from hair to hair, forming the vocal ligament, is attached further back to the arytenoid cartilage. The anterior part of the conus elasticus is firmly attached to the thyroid cartilage, forming the cricothyroid ligament, which we saw earlier. Here's the right half of the larynx, with the mucous membrane intact. The conus elasticus is just beneath the mucous membrane, here. The mucous membrane is closely attached to the vocal ligament and also to the inner aspect of the arytenoid cartilage. At the level of the vocal folds, there's a narrowing between the walls of the larynx. Its anatomic name is the rima glottis, but in this tape we'll refer to it as the vocal opening. Its shape is extremely variable, depending on the movements of the arytenoid cartilages. Here's the vocal opening in a living person, seen from above. In quiet breathing, the opening is diamond-shaped. When we breathe deeply, it widens to a triangle. When we speak or sing, it narrows to a slit. When we hold our breath, it closes completely.
Transnasal endoscopy and anatomical tutorial, produced by Fokker Ear, Nose, and Throat Consultants of Warrenton, Virginia. Endoscopy is ready to commence. Here we have a view of the anterior nasal cavity, the inferior turbinate.
So we're going in through the nose. We've talked about the fortuitous confluence of the two passageways. We're going through the nose, and he's taking an endoscope and taking us into the vocal cords. As you can tell, this person swallowed
It
it
is
in
what
three points.
humidifies the air we breathe. The endoscope is being passed through the nasal cavity to the posterior aspect. Please note the soft palate. The soft palate moves up and down with certain speech tasks.
Say baby bottle.
Baby bottle.
The endoscope will now be passed inferiorly where we will get our first glimpse of the voice box. Note the posterior laryngeal wall squeezes together as the pitch elevates. Here we have a good view of the voice box. The arytenoids are what move the vocal cords together as well as apart.
So paradoxically, the cords are shortening as
The
the
strobe light will now be turned on. The
That's
strobe
strobe.
light allows us to visualize the vocal cord vibration. Note that as the pitch elevates, the true vocal cords become longer and thinner. When the vocal cords are apart, we are able to breathe in and out. A voice is created when the vocal cords come together and start to vibrate very quickly. The endoscope is now being removed carefully.
So they're removing the scope. I wanted you to see the strobe there now. And what might happen if there's a paralysis, either paralysis on one side or both? This was a former student. I think he worked in an auto unit of some type of what sort of laryngeal unit, and he had a patient with this particular problem. So notice that the two vocal cords, the two cartilages, do not occlude and they don't close properly. In effect, you have a virtual paralysis of one and the other one's trying to compensate. And what would be the consequence of that, do you think? It certainly, yeah, it would certainly be very difficult speaking. There's another little video here from the voice doctor. He's going to tell us.
Vocal cord paralysis means that you can't talk
You can't speak.
or constricted and can't
We'll try to get the volumes up.
I do not know.
I have no idea. No, I have no idea. I couldn't talk.
Hello, I'm Dr. Thomas. I receive emails every day about voice problems. I received an email from a delightful 80-year-old, Peter, who lives to talk. His entire family talks all the time. He had a very unfortunate experience, however, of 5 years ago developing a anaplastic cancer of his thyroid. His voice hadn't changed. He underwent radiation therapy, and then he had a surgery to remove the cancer. The cancer's gone, hasn't come back, but 24 hours after the surgery, he lost much of his voice. That is, his voice became weak, and it stayed that way for the past 5 years. His main complaints are that he can't compete with background noise, such as when he goes to a restaurant, his family can't hear him anymore, and that the more he talks, the more his voice gives out. Now, why does he have these complaints, and are they related to his vocal paralysis? Let's take a listen to Peter's voice.
Man's first boat. Long ago, men found that it was easier to travel on water than on land.
Now we hear that Peter's voice is actually normal, in the sense of normal. We could hear every word he said in this recording. And that leads us to one very important point, the distinction between speech and voice. We can make a distinction by drawing a line on my neck here, just above the Adam's apple. Everything up here has to do with speech, that is, we make words and sentences with our mouth. Everything from that line down has to do with sound production. The vocal cords generate a pitch, and they control volume. Peter has problems with sound. He can't get loud enough. He can't be heard long enough. But as you heard, he can speak normally. The tongue, palate, the lips, they're all working fine. He can communicate. So the first notion to dispel is that vocal cord paralysis makes you lose your ability to speak. It does not. Let's also take a look at his vocal cords and see if we can identify what a paralysis is. First, I'm going to take you on a tour of normal vocal cords. Let's look at the picture. Okay, let's do it again in slow motion. If we watch these vocal cords, we can see there's one on the left and one on the right, and that they come together when we want to make a sound. Now, let's look at Peter's vocal cords.
E.
Let's look at it in slow motion so we see the detail. On the right side of the screen is Peter's left vocal cord, and it's opening and closing completely. It comes all the way to the middle. However, on the other side of the screen, that vocal cord was motionless. The right vocal cord is sitting still. The right vocal cord is paralyzed. Now, it's fortunate for Peter that it's fixed in a position where his good left vocal cord can close and meet it. That means when Peter's vocal cords come together all the way and he blows air between them, they vibrate. And he has a functional voice. If I take you on a tour of Peter's voice box and we watch again the closure, there's a subtle detail that I'm going to slow down and show you. And that is that as this left vocal cord comes closed, it meets the other one. And then, as Peter puts air underneath of it, the right vocal cord actually bulges out. Now, what does that do? That creates a gap between the vocal cords. And that gap, air leaks through. Air leaking through your vocal cords creates white noise, like a whisper. And that's why the quality of his voice has changed. That
You get the idea. In some cases, they can take, if the paralysis is muscular, in most cases not much can be done, but in some cases they can take part of the innervation from one side and feed it over to the other, and that can be helpful. We've already talked about the innervation. We've already talked about the fact that the nerves supplying the intrinsic muscles are largely branches of the vagus. These muscles are innervated primarily by the inferior recurrent laryngeal. And then it is also branches of the laryngeal arteries. The laryngeal arteries are branches of the thyroid. We'll look at the thyroid artery in more detail later, that also perfuse these muscles. There are a few slides here on surgical procedures intended to facilitate airway opening. I just want you to be familiar with the terms. You can see up here cricothyrotomy, tracheostomy. In general, what we're doing in a procedure such as this is we're opening the airway to allow air to pass to and from the lungs, assuming there's some type of blockage. It could be a mechanical blockage, above or below. Sometimes we'll talk about that. But sometimes there could also be trauma here. There could be a collapsed airway. So the location of the incision and placement of any tube would in large part depend upon where the lesion or blockage or where the trauma is located. But as the term indicates, a cricothyrotomy would be between the thyroid and the cricoid cartilages, whereas if you're involved in a tracheotomy or tracheostomy, then of course we're inferior, we're down here. Now, as you look at some of these illustrations, what is the real danger in cutting in this region? Yeah, you've got nerves, you've got blood vessels. In fact, some individuals, as we'll see later, have a blood vessel going right up the middle there. So yeah, bleeding, possible neurovascular issues can be very difficult sometimes to deal with. There is also a somewhat dated, I've pretty much given up on this distinction, distinction between otomy and ostomy. What's the difference between an otomy procedure, tracheotomy, and a tracheostomy? So an otomy just implies you're creating a hole. All right, so you have the big pin on the airplane, and you jab it into the person's throat. That's what they always do. But you pull the pin out, and you may not be any better off. So the ostomy implies a placement of a tube to keep to a continuation of the airway. But I find that the distinction isn't really observed all that much these days. And you can see in the illustration here where they've had to separate a portion of the thyroid gland, and you can see, in fact, the level of the incision is right there at the isthmus of the thyroid. You can cross this slide. I just put it in for historical interest because I don't think they even use this term anymore. Anybody familiar with the Heimlich maneuver? I think they now just call it abdominal thrusts. Anybody know why they call them abdominal thrusts?
For choking?
Oh, no. Nobody ever heard anymore. Heimlich got into a lot of trouble for a variety of reasons, and my only point here is that sometimes that decisions are made about terms and concepts and so on for rather socio-political reasons more so than the substance. But I don't think in your clinical training you will hear about Heimlich maneuver. You will hear about abdominal thrust. For one thing, Heimlich, I think he's still alive, has argued that, I may have this backwards, but I think he argues that HIV can be cured with malaria. And so he tried to, well, you can imagine how that wouldn't work out. And then I think there were some allegations regarding his son or whatever too, so I don't know. In any case, I just thought that was an interesting historical note. All right, let's continue our examination of the neck. We've talked about the blood supply to the neck. We've already indicated this very critical region in the neck here, where the common carotid bifurcates into the external and the internal. And this is, like when we're talking about rheology, the movement of fluids through tubes, hydraulics, and so on, that anytime you have a branching such as this or a sudden change in the direction of flow, that can create eddies and other problems that may result, for example, in the deposition of plaque. That we indicated was a problem of the arterial circle as well. So just be familiar with those major vessels that are supplying blood to the head via the neck. We talked about the vertebral arteries. In most cases, the vertebral begins at, the vertebral artery enters the cervical vertebra at number 6, and about, I don't know, 5–10% of folks, it'll actually come all the way down to 7 and enter through that transverse foramen. And then you can see it, the vertebral arteries enter through the foramen magnum. We've already seen the remarkably tortuous pathway that they entertain as they approach the skull. Note that the differences on the left and the right side with respect to the carotid. On the left side, the carotid branches directly from the aorta. On the right side, it branches from the brachiocephalic trunk. And we'll talk more about that when we talk about thorax. You need to be aware now, at least anatomically, we'll talk more about in the physiology of the two other critical regions right here, two other critical structures, the carotid sinus and the carotid body. The carotid sinus and the carotid body. I put a couple of illustrations. I know you don't have them in your, well, I guess they're not here. I put them in mine. They're gone. But actually, let's you look right here in that illustration. I spent 30 minutes transferring files this morning to absolutely no effect, apparently. But the carotid sinus, what do we mean by sinus? What's a sinus? Opening, yeah, in general implies something. So the implication here is that at this bifurcation, there's an enlargement of the carotid. That's the carotid sinus. And then adjacent to it is this thing called the carotid body. And you'll notice the primary difference between the two is that there's a difference in innervation, but that the sinus is chiefly important for baroreceptors, the body for chemoreceptors. And so you're going to learn later that your autonomic nervous system is monitoring both blood gas levels and blood pressure in order to regulate heart rate, stroke volume, and so on.
You said the body has chemo.
Yeah, the body is primarily important for the ability to detect oxygen and carbon dioxide in the blood. We'll sort that out later. It's a little more complicated. Let's just deal with that in physiology. It's a little bit it's more complicated. So this is a general summary of some of the structures we've already talked about. You can see, for example, the carotids in the top small illustration. You can see the drainage via the neck through the jugular veins right and left. And then remember, in the neck, the internal jugular is much larger, much more massive than the external. And we'll come back and look at the relative functions of each of these two vessels in just a moment. Now remember, in our discussion of the venous drainage of the head, we sort of came down here to the retromandibular system on either side, and then we said the retromandibulars would empty into the external jugular. As we continue down into the neck, you also have this system on the anterior side called the anterior jugular veins. And that's about all I can say, because what you need to appreciate about the anterior jugular system is that sometimes you will have paired veins, sometimes you will only have one vein, sometimes you will have two veins, but they'll be highly asymmetric. Oftentimes there's what's called the submandibular and submental veins up here that will connect. Sometimes they don't, so just don't expect a great deal of consistency. But all of this anastomosis with the retromandibular and the external jugular. You can see in the cadaver here the anterior jugular. And this is just included to remind you that you will be involved in procedures where you have to either access one of the jugulars, or perhaps one of the subclavian. You can see the person accessing the subclavian here, perhaps to take some blood, or in a few cases introduce something into the bloodstream. And what is the danger here? What is the danger playing around in this region at the root of the neck or the base of the neck with needles? You want to stay away from the high pressure side. All right. So nowadays, all of this if you are involved in this type of procedure, if not fluoroscopy, there's going to be sonography that makes darn sure that you don't poke where you shouldn't. But you can see, how is this person? This apparently was pre-sonographic. How is this person ensuring that they're introducing the needle into the right location? You can see they've learned a little manual technique there. Once they found the jugular notch, and then they move the fingers such a distance away from that. We will learn, or we will talk about in the physiology course, that right heart function is often indicated by the degree of distension in the external jugular. There's a valve between the aorta and the left ventricle, but is there a valve between for example, the right atrium and the jugular vein? No. So any increase in pressure in that atrium is going to be, any increase in venous pressure in the atrium may be reflected in the external jugular. If you can see up here, this elderly gentleman probably has some right side congestive heart failure, and that might show up as increased pressure here. So these vessels can be clinically useful for that purpose, and we'll talk about that later. In the old days, they would put patients on an inclined table and watch how they would respond to moving the head above and below the heart. Now, we've been talking about the external jugular. Just keep in mind that we talked about the cranial sinuses and all that blood that was entering the cranial sinuses that came down to the transverse sinuses and then the sigmoid sinus. And then there's a region right in here called the jugular bulb, jugular sinus. It too goes by a variety of names. But this is the point at which a lot of that posterior blood in the dural sinuses eventually ends up in the internal jugular vein. And you can see again how much larger the internal jugular vein is. And then I think we pointed out before, you sort of see it here, that pterygoid plexus. That pterygoid plexus and the maxillary vein and a few other of these veins tend to also interconnect the drainage from the internal and the external jugular veins. You see the massive internal jugular in the cadaver. Just a reminder that the spinal nerves coming off the cord in all regions of the spinal column emerge pretty much in the form of spaghetti, as you see here, with the only exception being the thoracic region. So they come out as spaghetti in the neck, and they come out as spaghetti in the lumbar and sacral region too. And by spaghetti, I mean, you can see what they're doing here. The spinal nerve emerges at each level, and then it hooks up with one above or below, and then you get this confusing morass of interconnections. That confusing morass of interconnections is called a plexus, at least in this context, we call it a plexus. And the cervical nerves 1 through 8 are divided into 2 of these plexuses. C1, we'll just say nominally C1 through C4, it's actually C1 through C5, form the cervical plexus, and then sort of C5 to C8 or even C5 to T1 form the brachial plexus. So we've already talked about some of the important functions of the cervical nerves. You can see the dermatomes here. You know what a dermatome is. We've also talked about the importance of efferents from the cervical plexus innervating a number of the neck muscles, the strap muscles, and so on. We're going to learn later that the brachial plexus is most important for providing innervation to the upper limb. By the way, in addition to the functions we just mentioned about the cervical plexus, the dermatomes, the muscles of the neck, notice also that the cervical plexus gives rise to the phrenic nerve, and the phrenic nerve innervates both the pericardium and the diaphragm. And then you can see the little dorsal rootlets here. By now you know if you can see dorsal, you should think sensory. You can see the relationship of the rootlets to the cord and how they eventually coalesce to form the peripheral nerve in the cervical region. What we're looking at here are the cervical dermatomes in the cadaver. You don't have to memorize these, but I do want you to be familiar. You can see a sort of chevron shape in the upper dermatomes, and then it tends to flatten at the base of the posterior neck. Here we can simply see that brachial plexus emerging and then leaving to enter the upper limb. You can also see the relationship here between the internal jugular vein and the common carotid artery at the level of the neck. Now that you know the triangles, we've already indicated as well that quite a few structures can be accessed via the anterior triangle. The anterior triangle primarily implies a point of access or a region of access for structures traversing, extending from the head to the thorax. And that would include most of the cranial nerves. You have to stretch a little bit here, but that basically includes 7, 9, 10, 11, and 12. Only cranial nerve 8 is not included in this group of the upper higher than the submedullary cranial nerves. We're going to come back and look at the vagus in more detail in just a moment, but the vagus in general in the neck descends bilaterally. As it does so, it tends to move more laterally toward the base of the neck and anteriorly, and that'll be important later. And then the final complexity here is that both divisions of the autonomic nervous system in this region, remember, the vagus is parasympathetic, but you also have cervical ganglia. They tend to become much more diffuse. We're going to have this problem as we continue into the thoracic and abdominal cavities. But what I mean by that is that these parasympathetic and sympathetic fibers tend to branch out and form networks around various tissues, such as periarterial plexuses that we've already encountered. But in general, as you look at the descent of the vagus here, again, becoming more lateral as it descends, and then it tends to proceed somewhat anterior, and then it does give rise, for example, to that superior laryngeal, and it will come back to the inferior laryngeal. But remember, that inferior laryngeal goes all the way down, and it comes back up into the neck after passing under the aorta. Now here's a curious arrangement too. We've talked about the importance of these projections of the cervical plexus. So you can see the cervical plexus here. You can see the hypoglossal nerve. That's the large nerve that you see descending here. And you already know its function. Hypoglossal is basically the nerve for the tongue there, both the intrinsic and extrinsic muscles. But what we want to pay attention to now is this curious arrangement. You have several slides illustrating this. You have this little loop, neural loop here that goes down, follows the hypoglossal for a time, and then it branches off to innervate a large number of these infrahyoid muscles. And then you can just sort of see what we have then is a sort of a loop. It's called the ansa cervicalis, the cervical loop or the cervical ring. And you have a couple of pictures here. This is showing the same thing. Here's the cervical plexus, C1, C2, and C3. This loop, this entire loop then here is called the ansa cervicalis. And so a portion of it descends along the hypoglossal nerve, between the internal carotid and the internal jugular vein, and then continues on down to innervate everything from the geniohyoid, the thyrohyoid, sternohyoid, and so on. And sometimes you'll see reference to the descending cervical and the descending hypoglossal branches, but it basically forms that curious loop. Ansa cervicalis. These are components of the cervical plexus. The transverse cervical nerve, you have a couple of slides on that. This is a cutaneous nerve. You can see the branch here coming off C2 that supplies the cutaneous region for the submandibular and submental chin. And you'll note that it skirts and overlies the sternocleidomastoid there. Here it is going the other way. Right on top of the SCM. We've already talked about the precarious position of the spinal accessory nerve in this region. The spinal accessory nerve is running right smack dab through that posterior triangle. And so it's kind of exposed there, and therefore it has to be anticipated in any type of surgical or puncture procedure in this region. And of course, the accessory nerve is innervating the SCM and the trapezius, as we talked about before. And I think they'll teach you some type of manual procedure, manual mnemonic you can use later to ensure that you don't puncture either the external jugular or damage the spinal accessory nerve in this region. You see the general axis and the orientation of it there. Now, when we talk about deep structures of the neck, this is something of an anatomical artifice. What we're really talking about in those regions deep to the what's called the visceral layer of the neck, and just anterior to that muscular layer, all that vertebral and muscular. So there's a layer called the prevertebral up here, and this is not clearly emphasized, but when we talk about the prevertebral muscles, all that I want you to remember is in that layer, that anatomical layer between the visceral neck and all those muscles in the posterior neck that are positioning the head. These include the scalenes. You can see the middle posterior and anterior scalenes, the levator scapulae. We looked at the rectus capitis earlier when we talked about the suboccipital triangle. And I guess I was looking for another one here. The only other one I guess we'll look at is the longus coli. If you look at the illustrations here, coli just means muscle. Longus means very small. No, longus means short. So here's the longus coli down here at the bottom, and here's the longus capitis up here at the top. So these are the two longest muscles, and they're both part of that prevertebral layer. And then you can see the scalenes over here on either side. And I think we pointed out that the problem you're going to have as a PA with those scalenes is that stuff is poking out between them. And sometimes the nerves and the blood vessels poke out in the right spot, and sometimes they don't. When they don't, and the patient turns their neck, that can be problematic. Once again, the longus coli here, longus capitis up here. And again, these are the scalenes back here. You can also see in this illustration, you can see components of the cervical plexus and the brachial plexus down here. What we're looking at here are the pharyngeal constrictor muscles, and these muscles sort of radially wrap themselves around the esophagus, and they do so in a rather voluminous fashion. There are three layers, there are three bands of the constrictors, superior, middle, and inferior. You can sort of see the relationship of these to the cranial structures. This is the superior, middle, and inferior pharyngeal constrictors. we will look at these are termed arteries in the root of the neck. I think for our purposes, we're going to treat these more as thoracic structures. So I'm not too concerned about your identifying or paying too much attention to the subclavian now. You should know, I guess, at this point, the subclavian eventually becomes the axillary. It does so at the lateral margin of the clavicle there. There are three parts. We won't worry about the three parts, but what I do want you to pay attention to as you look at this, because some of these are relevant for the neck. Notice that you have the vertebral artery coming directly off the subclavian. We've already talked about the importance of that. You have the thyrocervical, which goes both directions to perfuse the thyroid. And then, this is another large artery we'll come back to later, coming off this proximal subclavian. This is the internal thoracic artery. You can see the lateral thoracic over here too. And then, well, that really concludes most of the structures that are, or the vessels that are important for the neck. So you can see the vertebral artery ascending. We've already talked about that eventually passing into the foramen magnum and contributing to the arterial circle of Willis. Now, there are three critical neural structures that you're going to make sure you can differentiate. I can't tell you how many times I have stressed that students need to know these and know the relative position, and yet that isn't always achieved. So you'll notice in this cadaver, for example, we have the vagus nerve being pointed out there, little white arrows. Interior to that, over here, medial to that, are the sympathetic ganglia. So these are the sympathetic ganglia. And then over here, you can sort of see it there, the little nerve, that's the phrenic nerve. So here's the vagus descending. We saw this before, giving rise to those laryngeal nerves. So once again, in the cadaver, this is the sympathetic trunk. This is the vagus. That's the vagus there. And then this is the phrenic. And we've indicated the importance of the phrenic in innervating the pericardium and the diaphragm. All right, let's take a break. We'll stop there. Finishes.